Hi, my name's Professor Richard Harvey. I'm a rhinologist and I practice out of Sydney, Australia. Being a rhinologist makes me part surgeon, but also an immunologist of the upper airway.
Hi, my name is Dr. David Chin. I'm an ENT surgeon and rhinologist practicing in Singapore, and my focus is on conditions of nose and sinus.
So we're entering a really exciting phase, David, of managing our patients who have terrible type 2 or eosinophilic airway disease. We've got a group of biologic agents that have been produced on the market by various companies, and they've all undergone phase 3 trials and with variable effects, but all positive in influencing both upper and lower airway disease. I mean, it really has been one of the challenges in our profession to how to control this disorder without using systemic corticosteroid. There has now been a phase where we're looking at, they are slightly different. Many of these biologic agents are slight cousins of each other in terms of their treatment effect. They all work on the type 2 disease profile, some on an IL-4/13 basis and others on IL-5, whether the ligand or the receptor. And I think we are beginning to see in clinical practice that there are some patients that do better on one biologic than the other. So I think there are subtle phenotype differences that we see in terms of treatment response. I think this is still an area that we need to tease out. There's no doubt, though, that patients who have very high serum eosinophils seem to do well on anti-IL-5 treatments. This is one that has already been borne out in studies. The phase 3 studies that were done in many of these biologic agents they have variable inclusion criteria for the very populations that they're being managed. Some of the studies included huge proportions of patients who'd never had surgery, and you would assume have relatively milder disease, maybe not from a symptom perspective, but they certainly don't have fibrous polyp formation in some of those patients, and you might expect that the treatment response is going to be a little bit more dramatic if you've included a lot of patients who've never had surgery. But if you have a study such as tezepilumab included, everyone had to have surgery and you had to essentially be ready for your next operation, and 30% of them had 3 or more procedures. You're going to include a huge group of patients who have very fibrous sort of polyp and chronic remodeling change. And I think when patients and doctors are trying to compare the treatment effect of biologics, you have to look at the actual population and inclusion criteria, because the treatment effect is against the placebo group. And if the placebo groups are very different between the studies, it's very hard to make that comparison. So although people have tried to do this, I think that's a tricky thing at the moment. I think there's a bit of flaws in that. But on the flip side of that, I do think we're starting to see that there are some phenotypes of the disease that do better on one biologic agent than the other. And I think that's maybe an exciting world to see some more research come out. So when patients who have type 2 inflammation, we know that there's a range of cytokines that are involved in that type 2 inflammatory pathway. I mean, predominantly IL-4/13 and IL-5. These are the key cytokines. There are other cytokines at a higher level, such as TSLP, IL-33, IL-25, and there are some current phase 3 studies in some of the antibody therapies towards these higher level cytokines. But at the ones that we have now, 4, 13, and 5, I don't think we know yet enough about which phenotype of the disease might do better on one type of antibody than the other. There is no doubt, though, that we see a difference in clinical practice, that there are some patients who do great on IL-4/13 blockade, less so than IL-5, and vice versa. There are some patients who do very, very well on IL-5 blockade. Perhaps the only guidance I can, quote right now is just serum eosinophils. Those who have very high serum eosinophils seem to do well on IL-5, but this is an area of future research.
On that point, have you had patients where you've tried one biologic and then changed to another one and seen a different response?
Yeah, absolutely. I think actually, because our current suite of biologics that are available are all closely related, they all work. So if you have the right patient, someone with eosinophilia in type 2, they all get a response. I do expect now my patients to almost go into remission. Biologics at the moment are quite expensive, and so I really demand a very decent response from their intervention. I want to see the mucosa return back to normal, for patients to get near complete symptom resolution. This is my expectations, and if I don't quite achieve it, I do talk to patients about potentially swapping across to another biologic. I would say, though, that's unique. I think most people, when it comes to biologics, outside of being rhinologists, David, it's still going to be the right phenotype, that they're probably giving the biologic to someone who just doesn't have type 2 CRS. There's something else going on. And simply just changing from one biologic to the other is probably not going to be the success there, such as in allergic fungal rhinosinusitis, for instance. If you've got that condition, you can rotate through every biologic available. It's not going to help your situation.